I want you to think about the things which will affect your decisional balance and influence your sense of self-efficacy so that you might be better prepared to undertake a hypertension, right? We don't do that. And that's not to denigrate many of the models and processes that have been used in the past, but it's to say that times have changed. When we didn't have antihypertensive medications, it was very, very important that we emphasized non-pharmacological approaches to hypertension control, and it's very important that we continue to do so. But I also know that despite my best efforts in terms of trying to get people to adopt a DASH diet and walk 45 minutes 5 days a week, that probably central to my ability to prevent their stroke and manage their hypertension is to get them to take their beta blocker or their thiazide or whatever. So we need to be beginning to think very differently about how we identify this issue and how we deal with this with our patients. I went around the province probably for the better part of 5 years some time ago. This is a real mea culpa moment for me, right? Talking about the stages of change, which is a brilliant academic construct, you know, pre-contemplation, contemplation, preparation, maintenance. And we confused a whole generation of physicians who would say, okay, I want to do a stage-matched intervention with this. Now, is this patient a pre-contemplator or a contemplator? And there is absolutely no evidence that stage-matched interventions make any difference in terms of smoking cessation. And I want to suggest to you that in 26 seconds or less, you can deliver a state-of-the-art smoking cessation intervention irrespective of your clinical discipline or your setting, which alone will double spontaneous cessation rates. And it's something as simple as being able to say, you know, Mrs. McTavish, since you've had your heart attack, it's really important we both understand the most important thing I can do is to help you stop smoking. And I know that can be really, really troublesome, and maybe you've struggled with that in the past, but here at the Grand River Hospital we have a system in place which will probably make this much more likely to be effective for you. I hope you'll let us be of assistance with this, and don't ever hesitate to ask me for help. And this is just so important that I'm going to ask you about this every time I see you from now on. None of the, don't you want to see your children graduate from high school? Right? All right, you should be able to stop smoking. There's some things I can do to help you. I'm going to give you a little help. You should be able to do this by yourself. Right? We wouldn't treat hypertension by saying, we're going to start you off on hydrochlorothiazide 50 milligrams a day for 4 weeks, then drop you down to hydrochlorothiazide 25 milligrams a day for the next 4 weeks, and in the final 2 to 4 weeks of your hypertension control attempt, drop you down to 12.5 milligrams of hydrochlorothiazide, bring you back, measure your blood pressure, you're still hypertensive. When are you going to go away and think again about making a hypertension control? Right? It's a stupid parody, but the analogy I think is sound. We don't put plaster casts on patients' ankles and say, you fractured your ankle, the cast is coming off, it's been 6 weeks. But doc, it doesn't matter. The plaster cast is coming off after 6 weeks. And in no other area of clinical medicine have we established this concept that somehow there has to be great rigidity attached to the provision of treatment to deal with this unbelievably important risk factor. And let me cut to the chase. In terms of pharmacotherapy for smoking cessation, as much as it takes, for as long as it takes. And I have no qualms seeing patients on varenicline 9-10 months. I have no qualms about seeing patients with nicotine patches a year, 8 months, whatever. Because if I can help those patients stop smoking, that's among the most important things that I can do. And NRT is any patient, notwithstanding the NRT thing for a second, any patient receiving any form of pharmacotherapy for smoking cessation is infinitely safer than they would be if they were going to continue to smoke. With the exception being, because the evidence is not yet there, the use of varenicline in pregnant women. And yet there are colleagues across Canada who are now using varenicline in pregnant patients because they have made the conscious decision that the risk of smoking during pregnancy outweighs any theoretical risks of, but that's another talk, another time. So when you use NRT, you're delivering the drug via the venous system. You don't get 5,000 chemicals. You don't get carbon monoxide. Whole array of issues make this safer. I showed you this slide earlier, and you recognize this is that comfort zone. This is the level of nicotine produced by standard doses of NRT. In any other area of clinical practice, we call that a therapeutic gap. Doctor, you put me on metoprolol 25 milligrams BID. My blood pressure still isn't controlled. Yeah, you're right. Metoprolol is useless for blood pressure control. We should stop that right away. What do? We titrate the dose. And because smokers will titrate their nicotine intake with such uncanny precision, you can very easily and very effectively do this. And so we have standard schemas in our institution. If you're admitted and you're a 1-pack-a-day smoker, you get a 21 milligram patch plus the use of the inhaler so that you can titrate nicotine more precisely at certain times. If you're a 2-pack-a-day, you get 2 21 milligram patches, with the recognition that you may need to go higher. We're a cardiac setting, right? So we'll come back to that in a moment, because I know that I'm assuming many of you are saying, ooh, NRT, can't use that in cardiovascular patients. It's all about, with pharmacotherapy, opening a doorway onto a smoke-free future and recognizing that some of our patients will need that doorway to be opened wider. The dose needs to be titrated to meet their circumstances, very often in the case of NRT increased. And very often that doorway needs to be held open longer, meaning they need to take the therapy for as long as it takes. Delivery via NRT as opposed to smoking, you begin to understand that NRT is infinitely safer than individuals who would continue to smoke. And so one can use NRT very, very confidently and very safely in a cardiac population, because there is just nothing to suggest that the assumed risks are there. And I just draw your attention to this little cell, which shows that this was several years ago now, at the University of Ottawa Heart Institute in our coronary care setting, more than 70%, that number is probably 85% now, of individuals admitted with an acute coronary syndrome, a fresh infarct or unstable angina, get NRT within an hour or two of their admission, with absolutely no problem, right? And I can always hear the kind of the oxygen go out of the room when people go, when they look at this. But it's very important that we begin to consider so many of the factors that surround why why we can do this. And I've already alluded to them. You're delivering NRT in a totally different way. You're not giving carbon monoxide, which is very problematic for patients with coronary artery disease. It's being delivered in a steady state and at levels that are substantially lower than the levels of nicotine which would be achieved if that patient signed themselves out of coronary care unit, walked outside, particularly when it's minus 24 Celsius, and had a few drags on a cigarette. It makes abundant good sense in hospitals to have processes in place to identify and offer assistance to smokers. This is not about trying to get people to do things they do not want to do. We know that 65% of smokers who come for an elective admission view that admission as an opportune time for them to stop smoking, and they welcome the offer of assistance. In another context, many clinicians are somewhat inhibited about asking about smoking amongst patients because they say and they report, we don't want to offend the patients and we don't want to seem to be moralistic or judgmental or whatever. Paradoxically, patients judge the quality of care they receive, among other things, by whether or not physicians ask them about smoking. And so there are unique opportunities here which allow us to do things far more effectively. And so out of this came the Ottawa model. And the principles of the Ottawa model are that to identify and document the smoking status of all patients at the time of admission to a hospital. Has to be done, not left serendipitous kind of process. This must be done. It's on the care map. Somebody has to sign off that they've done it, and you don't ask, are you a smoker? Because many smokers will say no. They stop smoking 38 minutes earlier on a gurney in the emergency department. And their answer isn't intended to deceive. Their answer is for them the first opportunity to affirm their new, naively acquired non-smoking status. And so instead, you ask, have you used any form of tobacco in the past 6 months? Have you used any form of tobacco in the past 7 days? And only then will you get an accurate representation of their smoking status. That triggers an offer of assistance, it triggers the provision of pharmacotherapy, and it triggers a process which allows these patients to be followed for 6 months following their hospital discharge using some sophisticated computer and telephone kind of techniques. There is nothing that we can do in cardiovascular medicine which will have that impact. And as a consequence, we calculate in our own institution, which is a uniquely cardiovascular institution, we save 450 bed days a year now. And therefore, we're able to make much better use of our beds, more effective, which is a return on investment. The Ottawa model is now being delivered in over 115 healthcare settings across Canada, and the results in general hospitals are very typical of the kind of results that we saw in the Heart Institute, very significant, biochemically validated 6 and 12-month assessments, of smoking status. And we're also doing some kind of novel, innovative things. This is a pilot project we did in our setting, and it's now being expanded into a much larger study. To our patients who are coming for diagnostic or elective interventions or procedures, we asked them in this particular sample, we said, we want you to fast from eating and drinking from midnight the day prior to your admission, bathe yourself in antiseptic soap for 48 hours before you come to hospital, and when you get the call confirming the date of your admission for this elective procedure, we want you to put a patch on your arm every day from now on so that you can fast from smoking until you come to the hospital. That is all we said. 65% of those patients, often for the first time in 20 or 30 years, present for their procedure smoke-free, and more importantly, 35% of them are still smoke-free 6 months after that procedure. So demonstrating that we need to be much more innovative, much more unconstrained in the ways in which we deliver smoking cessation services and interventions to our patients. Couple of concluding points. We're not going to be able to help all of our patients stop smoking. That's not a reflective of our failure as clinicians. That's a reflection of the tenacity of this addiction. We need to change our metrics in terms of assessing how effective we are. Instead of measuring how many people we help stop smoking in a year, we need to ask how many people we help make a cessation attempt each year. Because I know the most powerful predictor of ultimate cessation success is the number of times somebody has tried to quit before. And on average, it takes about 2.5 to 3 quit attempts before somebody is ultimately successful. And by changing the nature of the relationship that we develop with our smoking patients, when our patient comes back and says, boy, I tried my best and it was really helpful, but 2 months ago I went back to smoking after being off smoking for 7 months, I can say, that's terrific. You stopped smoking for 7 months. Ordinarily, you would have smoked 7,000 cigarettes during that period. You smoked none, and I'll bet you went back to smoking at a time of a social situation or maybe a stressful situation in which alcohol might have been involved. How'd you know? Well, I'm a genius. I mean, but you've just demonstrated to me you can do it. I think that's absolutely terrific. Most doctors have no idea how difficult it can be to stop smoking. You did it, and I think this just demonstrates that you're going to be able to do this again. How'd you feel about getting right back onto this? So it totally changes our ability to help our smokers. And I'm often asked, how do we change the behavior of smokers? My answer is, it's more important that we change the behavior of clinicians and healthcare institutions so that we can be better able to help our patients stop smoking. The Lancet, not given to strident comments, in an editorial a couple of years ago, specifically aimed at cardiologists, said it's time for cardiologists to be less passive about smoking cessation. And for the first time in its 60-year history, the Canadian Cardiovascular Society adopted a position statement last November in Montreal in which it said, it is as important for cardiovascular specialists to now be as familiar with the initiation of smoking cessation pharmacotherapy as it is with the pharmacologic management of hypertension and hyperlipidemia. And it went on to say, it is the view of the Cardiovascular Society that all patients in every medical setting, outpatient, private clinic, or hospital, should have smoking status identified and documented and be offered specific assistance in initiating a cessation attempt. So the times, they are a-changing, with apologies to Bob Dylan. Right? I'm old enough to remember when cardiologists did not treat hyperlipidemia. That was deemed the province of the endocrinologist. And now that we are able to be more effective to help our patients stop smoking, I think you're going to see a sea change occur in a variety of clinical disciplines as we become much more effective, much more systematic, and begin to change professional and institutional practice in ways that will allow us to far more efficiently and effectively help our patients break free from the stranglehold imposed upon them by tobacco. Thank you very much for the compliment of the invitation to be with you, and thank you very much for the further compliment of your attention. Very much appreciated.